Welcome to Between the Sheets, the podcast where we're going to cover a variety of topics related to sexual health and wellness. I'm Dr. Stephanie Zwonitzer, your host. I'm a nurse practitioner and have been in practice since 2017. I have my Doctor of Nursing Practice degree, and I specialize in urology and sexual health. I am so excited to explore all of the various topics related to sexual health and wellness with you in a fun, spicy, educational, and non-judgmental manner. So come on, let's get between the sheets. Hey guys, welcome back to Between the Sheets. It has been a great week for me and I hope for you as well. I have a great guest on today and we're going to talk all things menopause and sexual health. Please welcome Dr. Angela Wright. She is a GP menopause specialist and clinical sexologist. She works in the NHS private and voluntary sector and is passionate about providing a safe and validating space to talk about the impact of our hormones that they have on us and about what is happening in our sex lives. She is trained in psychosexual therapy and is a fellow of European Committee of Sexual Medicine. Welcome.
Hi, thank you for having me.
Yes, I'm so excited. You know, menopause is a hot topic lately because for so long we were ignored as women. In research and in medicine, we were considered small versions of men. And that is just so not true. So I love that menopause is finally getting the due diligence it deserves. And I'm really excited to talk about this because I'm in perimenopause. And so I'm going through this and I know plenty of my listeners are as well. So what got you into the menopause area of life in your work?
So I always say that I did my sexology training first, and then I was, working in my clinical work and I was talking to people about sex. And it was really obvious that this was a part of life where loads of stuff happened with sex. So I did my menopause training after I kind of identified that this is a tipping point for a lot of women.
Yeah, absolutely. So what got you into sexology then? Because we don't go to kindergarten and think we're going to grow up and be a sexologist.
No, but then before this, I did end-of-life care. So I was trained in palliative medicine. I think I just like the conversations that other people don't want to have. Sex and death.
That's so funny. That's exactly what my background has been as well, is elderly care, end of life. Yep. I had a certification in palliative and hospice medicine. And then I found urology and sexual health. And it's those tough conversations. And some of us just really thrive in that area.
Yeah. And I think there's that experience of giving that space to somebody, people who are carrying a big burden of stuff that it's really difficult to vocalize. Yeah. We know from the data it's really hard for people to talk to healthcare professionals about these things. So it's really rewarding when you do. And I've always loved giving that space to people and offering them the opportunity to talk about this stuff.
Yeah, I agree. And you get to know people so deeply because of the topics. And once they feel comfortable with you, they really do share a lot and you can really help. I mean, it's amazing the relationships that I don't want to say I saved, but I helped them save based on the care that I could provide, the information I could provide. You know, sex is so important in our relationships, but also for our own personal health. I mean, we need to have orgasms to function healthily and all of those things.
Yeah. And the conversations, I often say to people that doing the job is a lot less sexy than people think. Actually, the conversations are about difficult stuff, about emotional stuff, about, it's really vulnerable to have a problem with sex and it feels really isolating. So, like you say, once you tell someone it's okay to bring me this stuff and I'm going to listen to it and I'm going to offer you some space and some exploration and maybe some ideas about what to do, it's worth a hell of a lot to the person sat in front of you. So it's really rewarding work to do and it's really impactful. I mean, it's something that I didn't know that I was going to end up doing for my whole working week, but I love it.
Yeah, absolutely. Absolutely. So talk to me about what you're seeing in the sexual health space in menopause.
Okay. So in the UK, there's been this big explosion maybe in the last 4 or 5 years about talking about this a lot. And I think it's really just opened a door for women to come to see a doctor or see a healthcare professional and talk about something that's been bothering them for a long time. And I think it's a little bit like when we had Viagra for guys. The idea that you can go and talk to your doctor and maybe raise the subject of testosterone or vaginal estrogen kind of legitimizes that path in. But actually what I find in practice is the hormonal stuff is it's really important. It's a very foundational part of what's going on. But what I hear more often is kind of burnout actually in women at this
Mm,
point of years and years of meeting everybody else's needs, carrying the emotional load, trying to play the game, be pretty, work, be a good family person, do all these things. And I think it's more of a tipping point actually for a lot of women where they've lost track of their own needs. And
yeah.
maybe what happens at menopause is that little bit of spontaneous drive that we were used to that maybe got us there with desire
Mm-hmm.
changes, and then the other barriers set in. So I think you have to be really holistic with the approach to what's happening at menopause. It's more than just the hormones.
Absolutely. Yeah, I've learned a lot. I've had a couple other people on here as well that are in the menopause world. And it amazes me how much, being out in nature and exercise and eating correctly, working out, getting the correct sleep, all of those things are just as important as making sure your hormones are balanced, and that some of those activities help balance your hormones.
Yeah, completely. I mean, my sexual therapy training really made me realize that like the autonomic nervous system stuff is really important. So if you've got people stuck in fight flight in their sympathetic nervous system, we know all the wiring for sex is not in that side, it's on the other side. So the more burdens you're carrying, the more you're doing at work, the more you're caring for elderly parents, as well as your own kids, as well as all the usual kind of household stuff. You're stuck in a part of your nervous system that I think puts the brakes on a lot in terms of accessing, the bits of desire, the bits of what your body might want or need
Yeah.
that allow you to find that space where you get aroused. So for me, that kind of wider setting of self-care, it's about context. It's about turning off the emergency mode and getting into another space where the nice stuff happens.
Yeah, absolutely. And acknowledging that what worked for us in the past might not be working for us now for arousal.
Yeah. I've got a lovely colleague who says that, in your teens and 20s, your body's like a microwave oven. Get into your 30s, it's more like a conventional oven, and it's a bit like an Aga when you get to your 40s. I don't know if you have Agas in the US, but these
No, what
really
are
slow
those?
ovens. It's really, really,
Like a
really
crock
slow. Like
pot?
those things. Kind of really slow.
Yeah.
It takes a long time to kind of warm you up and get you in the zone. But I think that stuff happens like outside the bedroom. I think it's all about setting the context for solo sex, but also for what's happening in partnered sex as well.
Yeah. And I think there's and I'm not sure how it is in the UK, but in the United States, it has been accepted for men to have solo time. It's just part of their culture. We're talked about it all the time. But for women, it's not as talked about. It's almost taboo. And I hate that for us women, because how are you going to have your partner help get you off and arouse you and all of those things if you don't practice and know what works for you?
I mean, I think it certainly when I was growing up, it was very much like that it was just accepted that the guys were up to this. And if you were a girl and doing this, like, you were never going to share it with somebody because that would have been weird. But
Yeah.
then the idea that if you think of your body as an instrument or a tool, the idea that you can understand how it works best by somebody else working that out for you is kind of crazy, isn't it? And actually, as
Yeah.
you go through stages, if you have babies, if you get poorly, if you have medications, if you go through menopause, a lot of what I talk about is almost remapping. And often that's, if it's okay with you, it's best if that starts with you, because it takes all the other complications out.
Right. Absolutely. What are you seeing with your ladies as far as their needs for arousal? What is kind of some major themes that you're seeing they need to even get there?
A lot of people will say to me that they wouldn't care if it went away and they never had sex again. There's actually it's quite interesting when you listen to people when they come in. Some of that seems quite relational. So if I've got people that are in a second or subsequent relationship, something that's relatively recent, and they're very emotionally connected, there's often more that they often miss their desire more. But often women in long-term relationships will say to me, look, I feel really bad about my partner, but actually for me, it's like I've been cut off. There's nothing happening for me from the neck down, and I don't care. So there are the practicalities that it can be difficult to get lubricated. Arousal can get muted or more difficult. It can be more difficult or impossible to climax. But actually, the biggest step I hear about is the willingness. It's feeling like it's something that's gifted to you rather than something that another thing that you have to give out. So some of that, I always start with the hormonal stuff because your volume switches down when you start to lose your hormones, right? So you get less of a sense of body doing stuff. But but some of it is actually about exploring, well, when did it become a duty? When did you get like kind of typecast and bored? And what can we do about changing that stuff? And that's more the therapeutic erotic world work rather than just the kind of retuning the body, putting the right things back in place.
Yeah, absolutely. I've talked to women about not even relying solely on your partner to get you aroused for that.
Yeah.
Listening to or reading erotic novels, talking with your girlfriends about what works for them, having your solo sessions so that you can get ready for that. And the hormone balance is a huge part of that. Now, in the UK, is it pretty easy and common for women to get HRT, or is that difficult? Because in the United States, we have very few providers. We have very difficulty with insurance. I mean, testosterone for women is not covered by any insurance program in the United States. And so I'm curious where you guys are at with things.
Yeah, so I think about 4 or 5 years ago, when this sort of menopause conversation started, I think 10% of women in the UK who could have HRT had HRT. The last set of figures I saw said it was somewhere up at 16 or 17%. The perception is it's everywhere. I feel like I'm in a bubble where I see a lot of it, and it's on social media, and there's a lot of conversations and talks. But I still think that's getting to the white, professional, educated women first and foremost. And when we look at areas with more deprivation, the prescribing's definitely down. So there's still loads of work to do. There's more private providers than there were. There's more charities and individuals talking about it. So access to education and information is much better. But it's hard to find the good stuff and work out what's true and what isn't. Most GPs, so in the UK, your family doctor's your kind of gatekeeper for the rest of it. Most GPs have some training in HRT, but before I was trained specifically in this, I would have given it to somebody who was struggling. I would have been really worried about breast cancer. I would have known maybe one or two products. And that's kind of the average doctor, I think, that sort of has that level of information, but more and more people are training in it. Still loads of barriers though. Testosterone's available, but not widespread, not everywhere. And most women, I would say that they really struggle to get hold of that within the NHS.
Yeah. Okay. And you guys have socialized medicine, like it's covered just by living there, right?
Yeah, so it is. And so the testosterone is really strange. So in some parts of the UK, it's on formulary. So it's kind of the government or the authorities that sit underneath them will say in one area what products can be given out by the GP. So in some areas, testosterone's on there. In other areas, it's only there if it's started by a specialist. So those women will need to be referred if there's somewhere to refer them to.
Yeah.
And there's barriers around, we don't have a product that is in the right concentration for a woman's body. So we nick the men's and we use that over more days, and that can cause problems. And I'm in two minds with testosterone. I think it's, like I say, it's an essential baseline that we should consider whether women need access to. But some of the conversation's been oversimplified in the UK in that if you're feeling that the bedroom's like less good, you just need testosterone. You just need a sex toy, you just need testosterone, and boom, you're back in the room. And like you say, it's often about like, where's my headspace? Have I accessed erotica? Have I had a single sexy thought in the last months?
Right.
And testosterone will give you a little bit more of that stuff, but it won't lift the blocks and the barriers.
Yeah, if you can't even like have your partner touch you because that just makes you irritable and cringy, you're a far away from enjoying arousal.
Exactly. Or if you have sex and then you're sore the next day and you have that urethritis, that kind of, or you get a full-blown UTI, and it's sandpapery for a lot of women. They will tell me that they're not dry, but they'll also tell me that they get this sandpapery unpleasant sensation when they're having sex. So I think there's a lot of lack of understanding about the changes that happen, and how it impacts.
Yeah, absolutely. Before I specialized in urology and sexual medicine, I didn't realize how impactful estrogen is on the urethra, the bladder, that you think about it being on the vagina. That's like, okay, it's a sex hormone, right? That's what we're taught forever. But the amount of things within the body, the processes within the body that estrogen is imperative for, just blows my mind. I will have women come in, perimenopause, postmenopause, and complaining about urinary symptoms, frequency, urgency. They've never had this issue before. They're having 2 or 3 UTIs a year now. And they're not even talking to me about the sex side of things, just the urinary side. And they're like so surprised when I suggest some vaginal estrogen, will re-thicken that bladder, will take away that frequency and urgency and the urethritis. And also it's going to make sex life better because you're going to be lubricated and your vagina is going to be more elastic.
And also the kind of the continence side of things, like, we know that people will worry about climacturia, peeing when they climax, and these barriers that we have. And we know that if people experience sexual dysfunction, there's often lower urinary tract symptoms present as well, because the same processes are happening in the body, right? So the education's really poor. And I'm on a couple of sort of social media boards for people on things like Facebook with that, tens of thousands of women having conversations, and the lack of knowledge when you read those conversations amongst the general population about what to do and when vaginal estrogen is needed is nuts. People, I was reading something about a woman struggling to climax, and there were maybe 50 comments, and only one of them said vaginal estrogen. Everything else was try a vibrator. And those things are great, but if you haven't got the nerves that are receptive and you haven't got the blood supply going in, you're going to really struggle.
Absolutely. And you can't blame the average layperson for not knowing these things, because they're not even taught to us as providers.
No,
we
completely.
have. Yeah, like you said, you went and got extra training in this. I've gotten extra training in it and learned things from other providers and wonderful guests that I have on here that make me a better provider. But we're not taught this. So how do we expect women who aren't in medicine to have any idea what would help them?
Well, I get on my high horse here, and I think that that's kind of the history of medicine stuff. That's all that stuff around us only knowing the full extent of the clitoris in 2005. Kind of it was out of anatomy books because of religious and social things around women's pleasure. So one of the things that dawned on me when I started doing the sexology work was, God, most of the products we have in the UK, they're intravaginal. We don't routinely talk about vulval, clitoral, labial application of estrogen, but actually in practice, a lot of the time, that's really helpful. But our assumption is around continuing to allow a woman to be penetrated, not around continuing to allow her to experience pleasure from it. So there's a mindset switch that that is miles behind where it needs to be.
Absolutely. So what are kind of some of the things that when women are coming in with these urinary symptoms, sexual symptoms in their perineum, what are your go-tos for them?
So I see countless women, I guess you will do as well, who've gone through investigations for recurrent UTI in their 40s, and no one's ever discussed the fact that this is bang on time to be part of perimenopause. I tend to tell people to do set things. I get them into a washing and moisturizing regime. So I tend to get them to use an emollient. It's somewhat controversial. I tend to say you can use emollients that you use for eczema, but with my therapist head on, they medicalize things. So I tend to like using sweet almond oil, coconut oil, something that's a bit more sensual. And my vulval dermatology colleagues say that they're very anti-allergenic and fine to use externally. So I get people to wash with oils, moisturize with oils. We've got some data that says if we use a regular massage externally, or turn a vibrator down low and use that on the vulva for a minute, a couple of times a day, that's really helpful for pelvic floor and for tissue strength or tissue supplety and health. I get women into self-checking because we start to see more lichin and, more melanomas and more changes. I see women get, a flare of herpes virus that they haven't had for years at peri because everything kind of changes. So I get them to self-check. And then there's the bit around the vaginal estrogens. Now, my patients are almost always initiated on those just to see whether things improve. And, then they stay on it lifelong. And then I would advise about lubes. If anything's going internally, most of us will find that it's better with lube and the less friction that happens. Like, you'll know this, but the turnover that happens in a fertile vagina in terms of surface cells and how quickly we repair from penetration, that gets really sort of slowed down when you get into perimenopause and beyond, especially if you don't have estrogens. So, it's important to reduce the friction and make sure that things are more comfy as well.
Yeah, absolutely. And I generally suggest a water-based lube. I'm not sure where you are, but that's for me, especially because of the recurrent UTIs that women are experiencing and stuff. I like to stay away from silicone ones. You don't want to use that with your toys anyways. Oil-based, maybe if you're doing like a longer session and you want to put a little bit of oil-based on first and then you're using the majority of water-based.
Together. Exactly. Yeah. So we do double glide, we're taught in the UK. So this idea of oil-based and water-based together is super slippy. So often I'll get my women to use a bit of oil-based on themselves. It's quite, if they like it, the texture is quite sticky, right? But it's also quite, it feels quite moisturizing and soothing. So when I don't know about you, I think of lubrication as being a little bit like erectile dysfunction in guys. I think for a lot of women, they're mortified by the fact that they're with a partner who is initiating sex and touch, and then the hand inevitably goes to touch and she's dry, and that feels like so it feels hard for a lot of my patients to use lube because they just want it to happen spontaneously. So I sometimes just talk about using the oil-based lube earlier, so there's something there that it kind of just building it into your routines, because once you've got a little bit of lubrication, arousal's often better and your own lubrication is often enhanced, isn't it? So there's ways of doing it.
I love that. There's a company in Europe called MV Health, or Mystery Vibe is what they used to be referred to. And they came out with a product called the Legato. And it's like a circular vibrator that you can you like wear it in your underwear.
Okay.
And yeah. And so it's for arousal, like it increases the blood flow and all of these things. And they actually have research studies showing about it. And so it's not, you can use it during sex, go for it. But it's really for women to kind of like have some control over their own arousal. And they have found that it's very similar to like a pelvic floor physical therapy schedule. Use it a few times a week for 20 to 30 minutes, whatever. And that the increased blood flow, the increased lubrication, all these things that come from the vibrations really
and also
make
the
a
connection,
difference.
right? So I think I often say to women, I think we get cut off at the neck, so the typical person with, huge load around caring responsibilities, work responsibilities, household responsibilities.
Yeah.
And I think we get socialized into pushing our needs down and not associating with discomfort. We're not encouraged to complain about period pain, endometriosis, pain in pregnancy, pain in childbirth. So we get quite disconnected. And some of what I put in place for women, that the daily massage is actually part of connecting. I get people to be mindful and think, okay, what's the pressure? What's the sensation? What's the temperature? You stand in a shower. I want you to do a sensory check. What can you smell? What can you hear? Because you've got to communicate with your body to get it to communicate back and start to get some sense of what touch you're missing or what you might want yourself, because we tend to focus too much on the partner whose need is really ready,
right,
and you can't hear your own needs in comparison to theirs sometimes.
Yeah, absolutely. I completely agree with that. And, I have friends who will come up to me and tell me like, hey, because they know what I'm in, that I do the sex stuff. And they'll come up and be like, I actually had sex with my husband last night. Like, and I'm like high five and I'm like, way to go. Good job. But, it stinks that we even get to that point. Like we should just be so in love with ourselves and our own arousal that we do desire it and we know we deserve that. But it has been such a long time in society focused on men and male pleasure, and women for sex. It's contraception and childbirth and pregnancy. And it's not about our pleasure, but it should be.
And it's kind of guarded. There's this theme of like, you tell your young women or your daughters or whatever, don't have sex before marriage. Don't sort of give it away. Don't have multiple partners. Don't. And so that sense of our own ownership over these feelings and these desires and so on, I think it gets really disconnected early because of social themes. So, and I say it gets kind of imprinted through life. So I think oddly, like the route into better sex and relationships is women owning their own pleasure, because if we're connected to it, then we start to want it and we start to dictate what we might like, and touch me like this, and I want to do this. But we're drowned out often. You can't hear your own voice through the rest of it.
Yeah. Absolutely. Yeah, I love that you talk about the mindfulness aspect of it, because that's something that I've really been learning in the last few years of how much our mind, it's this huge muscle, and it affects our entire body. And if we remove the brain from the way that we treat a patient, you're giving them half-assed care.
Yeah, completely. And it's like a big volume switch, isn't it? So I do a lot of work with women and men after cancer. And I think, to get through cancer treatment where you're having, invasive examinations, really unpleasant procedures, often on bits of our body that we associated before with intimacy, the way that people survive that is they distance themselves out of their head. They imagine themselves out of their body, and it becomes this reflex. Your body is no longer this safe place that you expect nice things to happen in. You're kind of distanced from it. So people recognize that. And then you tell them, do you remember when you really wanted? I don't know if do you have Toblerone in the US?
We do, yes. And it is delicious.
So I sat in this room in my office, and there was a giant Toblerone uneaten in my son's bedroom next door. And all I could think about all morning was how much I wanted to eat that. The anticipation, the mental waiting of how good that was going to be when I got my mouth around it. when I finally nicked that piece. And so we have the ability, if we anticipate something and we can't have
Mm-hmm.
it, to massively amplify how good that first taste is.
Yeah.
So our brain does loads with sex. And actually, after illness, after menopause, your brain is the biggest way to compensate for what you may find has changed in how easy your body is, going to
Yeah.
respond to things. But we have to phrase that well with patients, because I think you've got to not make that sound blamey. You've got to not make that sound invalidating, and almost make it sound empowering. Like, actually, look what your creativity can do. Look what your focus can do. Laurie Brotto, I mean, you must have come across Laurie Brotto, but she's done lots of work around mindfulness and sex. I love her work.
Yeah. Yeah. She's phenomenal. I love reading about her things as well and listening. And yeah, she's got a great take on things. Hopefully I'll get her on here too. Yeah. So talk to me about your patients who are coming to you. You know, we've gotten through the arousal part. They have embraced solo sessions, things like that. What else are you really helping them with in this, phase of life where they're at?
So I start with body. So I was taught by a psychosocial as my model. And I think, you've got to start with body. So you've got to do a scan of other medications they're using. Antidepressants are common in this group of women, and they can subdue climax and touch and stuff, and go through the list, sort the hormones out, systemic, local, with or without testosterone, do all the bits I've said about massage, lube, and everything else. And then you've got to think about the sort of sexual identity, relationship side of things. And often an exercise I do a lot with women is pleasure mapping, bigger than sex. Like, this is not just about sex. This is about your right to sensory pleasure, bodily pleasure in your daily life, and changing your focus to make that more central. I think we notice uncomfortable sensations if we're too hot, too cold, in pain or whatever, but often we don't have the mindset that it's okay for us to be selfish and to do the cat stretching in front of the fire kind of just languid, joyful parasympathetic nervous system pleasure. So I often say, look, what are the things that make your body feel good? All of the things, everything from, I went to a concert and I got goosebumps, they say music helps my body feel good, or I ride a bike and I go downhill in the wind and that always feels brilliant. I could do that forever. And you extend that, and you get them to notice, and also to pledge that they're going to build that in on a daily basis as a foundational part of what makes life worth living. And part of that is usually then to build in things that become a bit more sensual, become a bit more maybe self-focused. So the long bath that you take with the music and the whatever, you maybe take a toy in there with you, you take a bit of time out to think about and reconnect, because we need to have remembered pleasure, remembered reward for those non-spontaneous circuits to work. So spontaneous desire, like hunger, right? So it's an itch that needs scratching. Responsive desire, which is what most of us have in long-term relationships and becomes a bigger thing postmenopausally without the hormone kicker, is about remembered pleasure and an absence of things that block it, or, make you think you don't want to do something because there'll be a negative reward. So you have to kind of create context that allows you to have experiences which feel good, which then make you more likely to do that thing next time.
Yeah.
And some of that needs to be quite consciously built, like Lego blocks. People just don't have it to begin with, so you have to expose yourself to something in it. And then if you get a reward from that, you're much more likely the next time there's a queue. They say it's like walking into the supermarket and smelling the donuts baking and realizing that you want to eat.
Yeah.
Like, you've got a remembered pleasure. That's how you've got to access desire. And then some of it's about amplifying sensation, so using toys, using your erotic mind to bring in novelty and fantasy. Justin Miller's work's great. He reckons that midlife women have got the most colourful fantasies, like theoretically, because of the boredom, because of the lack of novelty.
Yep.
So working on that, normalizing that. A lot of women don't know that it's normal to fantasize, that it's okay to do that,
Yep. And it's not cheating on your spouse or your partner or any of those things. One thing I like to do as women are exploring is to suggest grabbing things from around the house when you do have that solo time, because you don't need to go and spend a gazillion dollars on all these different toys when you don't even know what you like. So grab the ice cream scooper. It's metal. See whether you like cold, hard touch. See, grab something else that's pokey and see if you like that. Grab a silk tie. See if you like the feeling of silk, and really allow allow those sensations to see what feels good, what doesn't, so that when you want to be aroused, you know what feels good, and you can gravitate towards those things to increase your pleasure and increase that session.
The idea, I think, that they often talk about this erotic palette and the fact that we only really work in like this tiny section of it. And for some people, you know, I love a food analogy, but, you know, if you grow up in a culture where the only food you get is, you know, typical of British food, like I only would have got roast dinners or whatever, how do I possibly know whether I'm going to like a Thai curry? How do I possibly know whether I'm going to like falafel? Or so some of it is removing the barriers that mean that we don't think we can look at those things. I think a lot of that is socialized into us, that good girls do this and, you know, you don't do that. But we also know that desire sits on top of novelty for a lot of people. And so that then gives us loads of scope for trying new things. And I think a lot of it is in the conversation. It's in the education that says actually that what we know about women's patterns of arousal is that actually they're much more fluid than men's are. There's studies that show that women looking at pornography will be aroused by same sex, opposite sex, you know, all sorts of different stuff, where regardless of their orientation, with guys, what they're aroused by just matches. And lots of women hold that and think, oh my God, you know, maybe there's something about me that I don't know, maybe I'm not. Or so just the conversation that goes that this doesn't change who you think you are. This is a kind of a standard for woman reflection of how our arousal works. And you can play safely in that, you know, it's okay.
Yeah, absolutely. And yeah, I think exactly what you said. I've heard many times in different studies about women and pornography watching, and how watching same sex or threesomes, even if you would never consider doing a threesome with your partner because of your own issues or beliefs or whatever, but watching that turns you on. And for other people, doing it turns them on, and they want that experience. And so I think it is like you're saying, just allowing yourself to remove the quote unquote societal norms and what we were raised with, to allow yourself to whatever it is that works for you and feels good is okay. And as long as you know, solo sessions obviously are consensual. That's all about you. But as long as whatever you're trying in a partnered relationship is, you know, consensual, then go for it.
Consensual. That's what they always say, right? And I think I was doing a talk earlier this week about the history of this stuff. And when you go back and you look at ancient texts, you know, way back in like Hippocrates' time, we were much more kind of open about observing human sexuality. But it was the religious stuff that came in that started to say, you know, sex before marriage was pathologic, solo sex pathological. And that stuff hasn't been really removed from how we learn about sex just yet. And many of the messages we get just teach us this is almost dangerous. People want it from us and we shouldn't give it to them. We might end up doing the wrong thing and be judged by society. So I think a lot of people squash it down, you know, and they don't have access to it. And then we wonder why we're not interested and excited. And there's an aliveness in the erotic that I think is really valuable, actually, in the face of everything that happens around perimenopause and menopause. So often your parents are getting old and dying, and your kids are moving out, and your relationship has been there for 15, 20 years, and you can feel a bit typecast and stereotyped. There's something really possible within pleasure and within the erotic to really add to quality of life. But you've got to make it accessible and make it and give permission almost.
Yeah.
Because the average woman, it's different. I think it's getting to be more different. I see more women who are really comfortable with their sexual selves than I did. But I think culturally, we still really have barriers to accessing all of that stuff with freedom, you know, with just joy rather than shame.
Yeah, absolutely. I mean, you even see it with adult sex stores. They're tucked in a back little corner. They're in a warehouse with no windows. They're, you know, you don't even know where they are unless you specifically search them out. And although we're getting a little better here in CVS, Walgreens, Walmart, wherever, you can find a couple cheaper vibrators or, you know, in by the condoms and the lube, but they're not necessarily the good quality ones that you want, but at least they're starting to be out there.
It's yeah,
it's interesting. So talk to me about the toys and the tools that you suggest, because I'm very much a proponent of really high quality products, because you're putting them in areas that have a ton of bacteria. They need to be easily cleaned. So talk to me about your perspective on that.
So I guess back to safe, sane, consensual, I guess if you look at the fact that, you know, like food or flavors or appetites, everything else. Far be it from me to tell you what to use. I agree with you. I think you need stuff that's easily able to be cleaned. You want stuff that's robust. There's some rules you always stick to. You don't put anything, for example, in the anus that hasn't got a flare at the end. So people need to know about that, because that's the danger zone. But there are things that I recommend frequently. I've got, one of them on my desk, flat-headed vibrators, I think, are great. So just for vulval massage. This one's got a little point that I really like for people who've got vaginismus and tension in terms of internally. Don't like dilators and trainers. People tend to find that sort of it's that still that feeling of forcing something inside. So matching it with pleasure, I think, is really nice. I don't know if you have O-nuts. I've got them somewhere knocking around. Yeah, I love my O-nuts. There they are. So I use O-nuts a lot with patients who post-cancer. They limit depth of penetration. I like clitoral suckers for women. We know that vibration sense gets a bit duller as you get older, in men as well as in women. So I do see quite a lot of ladies who used to love their vibrator, and then they feel like they just kind of can't tip over into climax anymore with it. So change of sensation to something like the air technology with a clitoral sucker can be a game changer. And you probably find the same. Women's patterns change. I sometimes find women in perimenopause, when they're getting surges of hormones, actually find new capacity. They can climax through penetrative sex for the first time. They may have female ejaculation for the first time, and that's never happened. Your body changes. And if you're able to remain curious and explore and stay open with that stuff, we know from the data that that's much better for sexual satisfaction scores than having one pattern going, I can't do that. Well, everything's gone because I can't do this one thing I used to do.
Yeah, absolutely. I love that. I think, and it goes for being in a long-term relationship too. Now, there are plenty of people who, as myself, we are in subsequent relationships and, you're divorced or whatever. But I think if you're in that long-term 20+ year relationship, you've got to get out of that rut and you've got to explore. And maybe going through perimenopause and menopause gives you that excuse to say, hey, things are a little different. Let's try something new. I tried something new in my solo time. Let's see if we can explore that same sensation together.
Completely. But you have to destigmatize it. And that's kind of the challenge we've got, is that it's linked in with aging. Aging isn't looked upon well, in our society. Most of our images of sex are still of young people. With these sort of one type of bodies having one type of sex. So I guess one of the things in the UK that's been really good about the conversation is we are seeing more images of women who are older still wanting to be sexual beings and still talking about that. And that slowly permeates expectations. But you can't be what you don't see. And, I think you have to have that you have to think of it as a freeing stage. And one of the consequences of the conversation that's happening in the UK is it almost sounds scary to get to this point. I think a lot of women in their 30s are getting quite frightened of this kind of, we're talking about it now, but we're talking about it quite negatively. And we need more voices of women who say, actually, I feel quite free at this stage. I am having, good sex. I'm in touch with my needs. I can vocalize. I've got a voice. I know what I want. And that stuff, I think, will filter down into how strutty you feel, how kind of, confident in your skin you feel.
Yeah, absolutely. I think, when we're younger, a lot of our internal communication with our own body is about other people, whether it's carrying a child or how can I function to make sure that I'm soccer mom at all the different things. Plus I worked this week, and, we're just constantly in tune kind of externally, or how our body is feeling in connection to what we can offer other people. And I think yeah, exactly.
Not its function, but how does it look?
Yeah. And I think what you touched on earlier about the change of life kind of phases in menopause is a lot of us, our kids are moving out. Maybe we're empty nesting. And if it is your subsequent relationship, maybe you're dating and those kinds of things, or maybe you're still in your relationship. But it is a time where we really need to celebrate exploration and kind of get internal to our body, to ourselves. And I think that's one of the positive things with the conversation of menopause now, is it's really saying, women, we know you're going through changes right now. We know there's 10 to 15 years that you're going to be going through major hormonal shifts, body changes, things like that, and figure out what works for you and how you feel during these phases, And I just love that we're starting to change that conversation.
Yeah, no, absolutely. And I think, if you approach it with the right head on, and you are aware that things are going to change, you might need to just put more effort into communication, exploration. I mean, what we know about, sex is that, like I say, novelty, obstacle, anticipation, there's themes that come up again and again in terms of what we desire. And we can use that stuff at this stage and at every stage we find things difficult, whether it's post illness or whether you've had a baby and the dynamic of your relationship has changed and you've got you touched out. Using it as a chance to kind of regroup and just reintroduce yourself to yourself and re-equilibrate, like, what are my needs? How does my body work now? What do I need to create the context for me to access this part of myself? This kind of what needs to have happened before the arousal, in terms of my rest, my quiet, my jobs being done, being able to put everything, all the baggage down so that I can be my sexual self. And the more we ask ourselves questions, the more self-knowledge we have, and the more we can create that, and the more we can ask other people to kind of join us in that. So I think it's really good that we're having the conversations, but we do have to have the right ones. And one of the things that troubles me in the UK is all of this complexity gets reduced down to, if you're struggling with sex, just ask your doctor for testosterone. It's like, well, it doesn't work if my partner's in the other room because we're sleeping in separate bedrooms, because I hate him, because he hasn't done, XYZ for the last 6 months. That doesn't help.
Right. Yeah. No, I love this conversation. All right. So one last overarching theme or your take home point for our listeners today, what would you say?
I'd actually say rediscover the art of a little bit of selfishness is probably the most important bit. It will have been knocked out of you in the average life by the time you hit menopause, and for sex not to feel like another thing that is demanded of you, it has to feel like something you're taking. And that means learning what you want, not what others need of you. So yeah, get a bit selfish and don't forget the hormones.
Yes, I love that. I love that. Thank you so much for being on here and talking through this with us today.
Really enjoyed it.
Yeah, great conversation. All right, everybody, we will see you next time when we get between the sheets again. Thank you for listening and spending time with me today. You can catch new episodes of Between the Sheets every Wednesday, because what better way to add some spice to your life than to have a new podcast on Hump Day? We will continue to explore common, uncommon, and taboo topics related to sexual health and wellness. Please send any comments, questions, or stories to podcastbetweenthesheets@gmail.com. That's all one word, podcastbetweenthesheets@gmail.com. Have a great day. And remember how important it is to discuss these topics with your friends, your family, and of course your partners. In fact, you can like, follow, and share this podcast so they can see it too. See you next time for more sexual health topics Between the Sheets.